Hey, what's up, everybody? My 230s. Hello. Welcome to Mr. Tagazon's channel on YouTube. I am Mr. T. We're going to be talking about Pilbeams, Chapter 7, Venting on Diseases, because we be talking about diseases and how we put them on mechanical ventilation. So here is a nice, big, fat equation for you. Now this one, shucks, I should have went over, but I'm going to go over it now with you. All right, so we can determine the desired FiO2, okay, by this equation. So, for example, it says desired FiO2 equals the PaO2, desired PaO2 times the known FiO2 divided by the PaO2 that is known. Okay, so here's a possible test question. Let's say the doctor interprets the blood gas and he says, I want an FiO2 of, let's say, golly, what do I want to say? Let's say I want a desired FiO2 of 40%, right? So here's what you're going to do. So what you're going to have is you're going to have a desired PaO2. Actually, let's see. Yeah, does your desired PaO2? Okay, so here's what the doctor's probably going to say. I would like the PaO2 to be, let's say 80. Okay, he wants 80. And FiO2 is known. Let's say the patient's on 40. And then your PaO2 that's known, that's going to be from your blood gas. All right, so I can give you these three values. And then you would have to calculate desired FiO2. Now, when we talk about desired FiO2, that just means this is the FiO2 you need to set the ventilator at to get the desired PaO2. Okay, so if you have a doctor that says, I want these blood gases look kind of bad on the oxygen side, all you got to say is, Doc, what would be your desired? Now, let me put it this way. If your PaO2 is low, let's say it's at 50 and the doctor wants it at 80, it ain't going to happen. I'm going to have to crank up that FiO2. Okay, so the desired has to be, reasonable. Okay, so if I had a PaO2 of 50, maybe I can try to push for 65, and then I can set my FiO2 based on that, and then right when it hits that point, you do the blood gas, then we can again move up on the FiO2 or move down on the FiO2 depending on if the PaO2 has been reached. Okay, so again, here it says if no baseline ABG is available, select a high FiO2 setting, which is greater than or equal to 50%, okay, for patients with presumed severe hypoxemia. All right, if they're desatting, then go ahead and choose a FiO2 setting. That would probably be your known, and then from there you do your blood gas, and then you can crank up your FiO2 based on your blood gas. Okay, and it says if start with 100%, reduce it as quickly as possible. Again, you don't want that oxygen toxicity. Okay, so we talk about sensitivity settings. We talked about that in lab. Here in Pilbeams, we're talking about flow triggering, and that we want to set the rate to 1 to 10 liters per minute below the base flow. Okay, so this is dealing with the triggering of flow. All right, so remember, you have flow triggered and then you have pressure triggered. Okay, most of the time we deal with pressure because we generate that negative pressure in order for the machine to kick in. Now, developing or generating that negative pressure is the way we normally breathe. So that's why a lot of times we're looking at pressure triggering rather than flow triggering. But just remember, when you're talking about flow triggering, you set it at 1 to 10 liters per minute below the base flow. But if you're talking about pressure triggering, you want to set it between -1 and -2 centimeters of water pressure, because it decreases their work of breathing. It's so much easier for them to trigger that breath rather than having them really fight for it and increasing that work of breathing. That's not what we as respiratory therapists do. Okay, so then we talk about humidification. In red, it says should provide at least 30 milligrams of water per liter of absolute humidity at a range of about 31 degrees Celsius to 35 degrees Celsius for all available flows up to 20 to 30 liters per minute. So again, we're talking about absolute humidity. We want to make sure that the patient is getting humidity. Why? Because we intubated them, right? We bypassed the nose and we're pushing air through the mouth into the trachea, into the lungs. So we lost the nose, we lost the nose hairs, we lost that ability to humidify the air before we breathe it in. Okay, same as if you have a patient who's been trached, they bypass the nose. There's no way to heat the air going into the lungs. Okay, so that's why we have to take humidity into heavy consideration. Okay, humidification malfunction is considered potentially life-threatening or a level 2 event. And imagine that, humidification malfunction. Why? Why is that considered potentially life-threatening? Well, I'll tell you why. If you have thick tenacious secretions, okay, one way we thin secretions is by humidity. The humidity binds with our mucus and it makes it much more watery, which allows us to either suction it out or have the patient cough it out easier. If I have thick tenacious secretions and I have no humidification, guess what? Those secretions can actually block airways, multiple airways. They can cause mucus plugs. Then what's going to happen? I can't get enough oxygen into my lungs and I can't get enough oxygen to support my oxygen needs throughout the body. I'm going to start shutting down. I'm going to start cardiovascularly shunting. I'm going to start putting more blood into the important organs, and I could potentially die. Okay, so now this takes me into just a little bit of a rant in terms of your HMEs. Guys, please be very, very observant of your HMEs when you do rounds. Make sure you do rounds. If someone has thick tenacious secretions, you do your rounds every hour and a half to 2 hours. You make sure those HMEs are not clogged. You make sure that if they're starting to get clogged, you can kind of like just flick the HME in the trash can, just get all those secretions out. Or if it's really, really caked, change out the HME. You can potentially kill somebody with the HMEs if they're totally clogged and you have no way of air passing through the HME. You can basically suffocate the patient and kill them. All right, so just be careful with the HMEs. All right, so but then if you want if the patient needs humidification for long periods of time, go with the heated humidifiers. Okay, the normal ones that we use is the wick humidifier. That's what we have at lab. Okay, or some people call them Fisher-Paykel's, and that's the brand that makes them. But normally they're called wick humidifiers. Wick humidifiers, okay? All right. So on contraindications for HMEs, and let me take a step back. HMEs are used for temporary. It's used as a temporary means. Some places they use them for permanent. And you change them Q12 or if they're just really, really caked and dirty, that's when you would change your HME. But it's supposed to be used for short trips. Like if I'm going to take a patient in subacute, if I'm going to take them to the showers and back, if I'm going to transport a patient from their room to activities, right? Or if I'm going to take a trach patient that came into my ER, I'm going to take them to CT. I'll pop in an HME. Okay, so again here, and I've touched this before, presence of thick, copious, or bloody secretions not cleared by suction. If they're just too thick, don't put the HME. All right, again, it says right here, change HME to heated humidification. All right, so that's the main concept here in terms of contraindications, because you can clog up that HME. It says that aerosolized medication must be given use an MDI instead. And we had this discussion in lab. Some students have asked me, do you keep the HME on when you run a breathing treatment? Now, I'm going to tell you this. It depends on the facility. And I'll tell you this also. Sometimes the facility does not have policies on HMEs, and if you're to remove them during nebulization of any medication. But I'll tell you this. The manufacturer states you need to remove the HME before you give a treatment. Now, I wanted to show you guys, and I don't have it. I don't know what happened to it, but there was an HME where you can just rotate a certain part of it and it'll read aerosolized. And that means that you can keep the HME on, and when you twist it and it says aerosolized, then it will allow the medication to go through uninhibited, right? And then when you're done, you just turn the dial back and it'll say HME, and it's going to continue to heat up the air. It was really cool. But I think those ones are pretty expensive, so you probably won't see those at clinicals. So you might just see the normal ones, like the blue ones, or you might have the white one with, it's a lot thicker, and then it'll have like a yellowish sponge inside. Okay, so again, with HMEs, just make sure that it's not blocking the whole entire HME, and that therefore no airflow can go in. Just watch those. Okay. All right. So for alarms. Okay. So here's what we decided, and I think I made the decision in the second lab. So first lab, please. I apologize, but I just want you to pay attention here. Let's just say for high pressure, we're gonna go 10 and 10. It'll make it easier for you guys. High pressure, 10 above PIP. Low pressure, I probably would choose the 10 below PIP. Okay, so 10 and 10. That's so much easier to remember. Okay, so for low exhale tidal volume and minute ventilation, we're going to go plus or minus 200. Plus or minus 200 on tidal volume. On minute ventilation, we're going to go plus or minus 2. Okay, plus or minus 2. So let me repeat that again. So high pressure, if you have to choose low and high, go 10 above and 10 below your PIP. For your low exhale tidal volume, we're going to go minus 200, right? So if you had a high exhale tidal volume, we'll go plus 200. And then again, if you have a low exhale minute ventilation, we're going to go with 10 below, or 2 below, I'm sorry. Because remember, our tidal volume is between 5 to 7. So if I pick the low end at 5, I subtract 2, that's going to be 3 liters a minute, and that's pretty low, but it's still it's a bit sustainable for the patient. So when they hit 3 liters, it alarms. I can go in there and adjust and get that minute ventilation back. Okay, so that's what we're going to use with our alarms. Now for the exam, go with what is in red. Okay. Go with what's in red. All right, but when we're in lab, and I'll remind you guys about alarms on Monday. I'll remind you of what I'm saying now. Okay, but for the exam on Monday, go with what you see here. Go with the red. All right. So let me take you back up here. Action during ventilator alarm situation. Basically, you want to make sure that the patient is being ventilated, and what you're going to do is you're going to disconnect and manually bag the patient. Okay, that's going to be your first priority. When the alarms go off, what you're supposed to do on an exam, I'm going to state it that way, on an exam or on the practicum, is you're going to disconnect and bag the patient. Okay, once you bag the patient, you identify that it's not the patient, it's not the ET tube that's dislodged or the trach tube is dislodged. You determine that you can ventilate the patient, then you start troubleshooting the machine. Remember, we treat the patient first and then the machine. Okay, so that's what you will do when the vent alarms happen. Now, in clinical, do we do that? No, we don't. Alarms come in, maybe you might need suctioning. All right, or you watch the patient. Just they might be biting the tube. There might be a kink in the tube, endotracheal tube. They might just be coughing, and it's causing a high pressure alarm to go off. All right, you never know. All right, but you want to make sure the patient's taken care of first. Okay, so there are times where we're going to have to do some type of hyperinflammation or sighing. So when you sigh, you just take a rather deep breath. You're not really thinking of breathing in very, very deep like you're doing an incentive spirometer. You just kind of, it's a short but deep breath, right? So the main thing in this slide I want you to know is that sighs are not recommended for patients with higher tidal volumes, okay, greater than 7 mLs. Why? Because then when you take a big deep breath, you're increasing more volume. All right. So when I increase more volume, I can possibly cause barotrauma. Correct? So that's why I want to watch. I don't want to give a sigh to a patient. Now, some of the vents have sigh buttons, so you can push that button and it'll give a sigh to the patient. All right. I'm not sure about the Dragers. I haven't really looked at the sigh buttons, but sighs are. I haven't really been ordered to give a sigh. So it's there if you need it. Put it that way. All right. So it's not recommended for patients with higher tidal volumes or in the presence of plateau pressures greater than 30. Again, we don't want to go over 30 in terms of pressure because that's going to cause some alveolar overdistension. Okay. Can be harmful for spontaneous breathing patients on CPAP. It's not for spontaneous breathing patients. Okay. Even though we're spontaneously breathing and we're not on a mechanical vent and we can take sighs, well, if you're on CPAP, it's not recommended because remember, you have constant pressure blowing into your lungs. If I'm going to take that big deep breath, that's going to increase volume and possibly increase some pressure also. All right, so we just don't want to cause any type of barotrauma. So when we talk about lung recruitment maneuver, right, we're talking about PEEP, we're talking about alveolar recruitment. All right, so our pressures here, it's going to be, when we want to recruit some alveoli, okay, so we want to crank up that pressure to 35 to 45%. Now, I know you guys are, oh my gosh, that's above 30, we're going to pop it, we're going to cause a pneumo. I can hear you guys saying that. But here's the thing. We're not keeping those pressures for so long. We're keeping it 40 to 60 seconds. All right, so we're going to ramp up that pressure, leave it for roughly around a minute, and then we're going to drop it, and that's it. Okay, get that stretch in. All right. Now, again, we might need more pressure. Why? Because a lot of the alveoli are collapsed, right? We have atelectasis going on. So we're going to need that extra pressure to force them to open, but we're going to force them to open for a short amount of time. Okay? So just some things to think about when you're setting up a patient for mechanical ventilation. Honestly, you want to, number one, check circuit function. You have the SSTs, that's what we do, and ESTs. And I know I didn't do that for us in lab because with the PB840s, if I do an EST, it needs some kind of like golden tubing garbage, and it messed up our ventilator, I think, the first term that I taught. So I don't want to mess with that. And then with the Dragers, I probably will show that to you next week. I think that, even though you really don't need to know in terms of Drager, in terms of the, the practicum, it might still be something to learn. So I don't know. I'll think about it, but just make sure that you have your circuits are functioning. Make sure on your on the Y you have a cover for the temperature port, and that time sometimes it falls off. Okay, and that's going to cause a leak. So you want to make sure that that port cover, and there's another port cover at the end of the inspiratory limb that connects to your bacteria filter, right? There's an elbow. Some of the circuits have elbows, and that has also a port where you can put a temperature probe. You want to make sure those are closed as well. And sometimes manufacturers won't close them tight, so you want to make sure that those are fully closed. Okay. And then also too, you want to make sure that the humidifier is used with sterile water. Okay, and you don't want to store water on top of the vent, even though at my old hospital we did, because it was so convenient. We had our clipboards for our vent checks on top of the vent, and then we had bottles of sterile water on top of it. Well, we got dinged because that's water on top of an electrical machine. So we had to put the water at bedside. All right, so you want to make sure you use sterile water. Don't use sink water. Don't use dirty water. Again, that's going into the lungs, which is sterile. Okay. So then if we had heated humidification, again, just put your temperature monitoring devices. This is near the patient connector. But we have ports for that, so we'll go ahead and plug that in. All right, so if we have to monitor temperature, okay. Check the FiO2, set tidal volume and respiratory frequency. Yes, that's obvious. Adjust the alarms, obvious. Now again, I have to state it. Every time you make a change in one of the vent settings, you adjust your alarms. Okay. This one, number 6, is connected to an... if they are in telemetry, if they have any type of heart issues, yes, you'll either have a Holter monitor, or you will have the patient in telemetry, and we're going to be putting them on our EKG monitor to see if there's any type of change in cardiac rhythm. So depending on where the patient's at, that's where, if they're at telemetry, then they're going to have a Holter monitor, or you're going to have cardiographic monitoring, electrocardiographic monitoring. So just make sure that the leads are on, because there are times where you're in the room, you're giving a treatment, all of a sudden it'll show that the patient's flatlined. And you look at the patient might be sleeping, and you're sitting there like, holy cow, I'm going to call the code blue. You call the code blue, guess what? Everyone starts moving, there's banging, there's noises, the patient wakes up. What's going on? You're like, oh my gosh, I thought you're dead. But then one of the leads just came off. Save yourself the embarrassment. Check the leads first. Make sure the wiring is okay. Make sure that you see chest rise, because that means the patient's breathing. Right? If the patient's breathing, they got to have a pulse. Right? If they're breathing and they have no pulse, then they're a zombie, and you got to stab them in the head. All right? So, I have an emergency airway tray. So I'm just going to, for this particular part, I want you guys I want to remind you that you have to have an ambu bag at bedside if you have a mechanically ventilated patient. Now with that ambu bag, or should I say manual resuscitator, you need a mask as well. Okay, regardless if they're trached or they're intubated, you need that mask. Okay, so if you have a trach patient, you may possibly want an obturator as well. So just in case that trach tube pops out, you have the obturator, you just put that trach tube back in and just cinch it down, take out the obturator, replace it with the inner cannula, and that will be that. Okay. Make sure your suction equipment does work. All right. There have been a couple times where I'm sitting here, I'm prepping to suction, and I use the ballot, I go down, and I'm like, hey, I'm not getting anything, and lo and behold, I forgot to turn on the suction machine. Remember, check the suction machine, and for adults, you want it, I believe it's -100 to -120. I think it's centimeters of water pressure. That's for adults. So that's your normal suctioning pressure. Okay. And then number 9, select the volume monitoring device and an oxygen analyzer. Now, oxygen analyzer, now you're talking about periodic maintenance of your ventilators. Okay, so your biomed person on the hospital will be the ones to look at your oxygen analyzers, see if they're fixed or not. Now, you can determine if your oxygen analyzer is not working because it might say something like low O2 sensor, or I think on the Esprits, it'll just say low oxygen, regardless if you plugged it into the wall unit and you have oxygen running through and it's saying low oxygen. That's probably the analyzer needs to be changed, and that's when you would have to pull the ventilator out of service, tag it, and let your lead or your supervisor, manager, director, let them know that there's something wrong with it and it might just need periodic maintenance. Okay, last but not least, again, I did state that you need a bag valve mask or a manual resuscitator at bedside. Okay, so again, preparation is always key. You want to prepare the patient. You want to make sure that you have all the equipment that you need. Okay. Then it says establish an interface, provide manual ventilation, ensure cardiovascular stabilization, determine ventilator needs, treat the cause of respiratory failure. So here you just want to make sure that everything is where it needs to be. All right. And the best time to prep for someone is when there are no emergencies. So, there are times where certain bosses will sit there and assign someone to look at, let's say, the intubation tray, make sure everything's working, make sure the laryngoscope lights are working, the batteries are okay. You have all the different sizes endotracheal tubes. You have the different sized sterile gloves for the doctors. All that stuff we have to double check and make sure just in case, so that when the emergency happens, we have all the equipment there. Okay, so preparation is always going to be key. Selecting the appropriate ventilator. So depending on the patient and what they are suffering from, that is what we will definitely use. Okay, so for example, if I have a patient with COPD, again, BiPAP is our go-to. All right. We don't want to tube them because they are chronically that way, right? So we don't see any issues. We want to prevent that. We want to help that acute on chronic condition. But again, we can't fix them. So technically it's all chronic for them. All right. And so we don't want to tube them. So we just want to make sure they're on bi-level. Okay. All right. So again, it says if intubation is necessary, an orotracheal intubation is recommended. That's just your normal way of intubating, yes. And this is clinician can select the ventilator mode that he or she feels is most familiar. All right, so it's going to be up to the doctor. Again, we can suggest certain things, but again, it's just going to depend on our blood gas. Okay, it says adjust peak inspiratory flow. Okay, so this is where we talk about flow: shorter I time, longer E time, blow off the extra air that's trapped, and they're good. Now this is saying increase the flow greater than 60. I probably would want to max it at 60 and then just observe the patient. Okay, flows of 70 and 80. I mean, that could work too. If they're definitely air trapping, you want to go higher up in the flow, shorten the I time so they can breathe out a lot more on exhalation. Okay, so patients with COPD and asthma, where airway obstruction and resistance are high. All right, so we still want to keep the tidal volume the same, 6 to 8. The rate is going to drop a bit. And instead of 12 to 20, we're going to go 8 to 16. Okay, I time is going to be between 0.6 to 1.2 seconds. But again, watch your respiratory rate. You don't want to go so high. All right, why? Because if you go high respiratory rate, they start breathing fast, correct? That means they're going to blow off more CO2. Remember, they are on hypoxic drive. Okay, so their breaths are triggered by high CO2 levels. And if I have my respiratory rate high, I blow off the CO2, I pretty much knock out their breathing, then I'm going to kill the patient. Okay, so watch your respiratory rate, but make sure your tidal volume still stays at 6 to 8. That's why I don't really like 8 to 16. That 16 might be pretty high. All right, so we want to make sure that we don't blow off a lot of CO2. Hey, last but not least, PEEP you want at +5 or lower, or about 50% of auto PEEP should be used initially. Now, I'm not sure about the 50% auto PEEP, because if they're auto PEEPing at 10, then I would have to set my PEEP at 5, right? So they're going to have to trigger, they're going to have to breathe 5 centimeters of water pressure. On top of that, I have that sensitivity at, let's say, -1. So they're going to have to breathe 6 centimeters of water pressure. So again, we had talked about increasing the PEEP up to the level of their auto PEEP, so it decreases their work of breathing. That still, that can happen, but you can also adjust respiratory rate or increase flow to help them breathe better. Okay. So here we're talking about auto peeping. So we want to watch for that, and then remember, we watch for that with the expiratory hold button. All right, you want to make sure that they are not auto peeping, or if they are auto peeping, you may not even have to press the expiratory hold button. You'll probably see it on your volume scaler. Yeah, pretty much the volume scaler. You'll see it. So they're still going to be retaining volume, so therefore they be trapping. Okay, so again, provide the longest expiratory time. We've talked about that time and time again for the COPDers. You want a lot more expiratory time to blow off that excess CO2. All right. If auto peep is present, set peep near 80%. Okay. So now they're saying about 80% now. But it says, but do not exceed it 3 to 5 centimeters of water pressure is often adequate. Now again, you have to think of COPDers and their hypoxic drive. So if I increase the PEEP, what am I basically doing? I'm doing alveolar recruitment to improve oxygenation. But do they breathe on oxygen? No, they breathe on carbon dioxide. So if I flood the COPDer with oxygen because I increase the PEEP, guess what? I'm going to knock out their hypoxic drive and I'm going to kill them. Okay, so be mindful of that. All right, really quickly here, if PEEP begins to rise because PEEP is rise because PEEP is increased, the safe PEEP level has probably been exceeded. Okay, now this is talking about doing like PEEP studies. What's it called? Optimal. There you go. Optimal PEEP studies. So there are times where if I put too much PEEP, I'm going to start driving up the pressures. I'm going to influence cardiac output in a negative way, and it's going to jack up the patient. So we have to just be mindful of PEEP, and we'll talk about optimal PEEP studies on Monday. Okay. A plateau pressure should be monitored and maintained below 30. 30 is our magic number. Again, maintain near the patient's normal PaO2 with the FiO2 less than 50% unless the patient's condition worsens. All right, so if they start desatting more into the 70s, yeah, I would probably give them a little bit more oxygen. But if they're at 86, 87, I'd bring that down to 2 liters nasal cannula. Okay, so with our COPDers on pressure control, let me see. Pressure control provides flow on demand to meet the patient's needs. Again, we're adjusting pressure to get their volumes up. The effort required to trigger breath equals the sum of the auto PEEP and the pressure trigger setting. Okay, so this is what we're talking about in terms of increasing the PEEP. All right, so if I have a patient with 8 centimeters of water pressure of auto PEEP and a pressure trigger setting of 2, patient would need to trigger a vent breath of 10 centimeters of water pressure. So this is what we're talking about in terms of bringing that auto PEEP up to match, or bringing up the PEEP to match the auto PEEP, so it decreases the work of breathing. So this is going to be definitely on your pressure control ventilation, not so much volume control. Okay, because with volume control, what we can do is we can also increase flow, and we can also decrease respiratory rate, and we can also increase tidal volume to help blow out that excess CO2. Okay, for asthma, again, asthma is restrictive and obstructive. Okay, so you want to think about controlling the airways, right? So it says it's easy to control airway pressure with pressure control. Okay, so with asthma, it probably would just depend on how bad they are, and if it's obstructive or restrictive type of asthma. All right, so you would use your PFER, right, to determine if it's airway resistance versus if there's some type of obstruction. Okay, so when we're talking about asthma and putting them on a vent, it says maintain peak and plateau pressures at minimal levels. PIP may be high due to high airway resistance. Okay, we know that. We know that airway resistance, it could be either a kink in the tubing, someone's biting the ET tube, bronchospasms, was it? Well, one of you guys said boogers, right? Boogers in the in the airway. So all of those is going to drive it up. So if I have decrease or high airway resistance, that's going to increase my peak inspiratory pressure. All right, so just watch for that, and then ensure that the patient's oxygenation status is adequate. Again, if they're not able to move air, like we saw with was that Kate, that teenager that we had in the ClinSim #1. It was Kathy, that's her name. Kathy had some asthma, and her PFR started dropping to 95. So again, we want to make sure she's oxygenating adequately. Again, we can go with permissive hypercapnia with these asthmatic patients, again, depending on if it's a restrictive or obstructive. And again, the PaCO2 of 45 to 80 millimeters of mercury is acceptable. And so, yeah, if we have to increase that CO2, then that's what we're going to have to do. Okay, so again, that's where permissive hypercapnia, that's with permissive hypercapnia, and if the doctor orders that. All right, so if the ventilator saying cannot accommodate the patient's needs, the use of sedatives and paralytics may be necessary. We're going to be dealing with some drugs. I can't remember which chapter, but we will be dealing with some sedatives and some paralytics. Okay, and this also ties in with a rapid sequence intubation, which I'm thinking you guys had at 220 because it's advanced airways. So we do sedate and paralyze the patient before we intubate them. So we don't have to get any type of gag reflex. We don't have to get any type of vomiting. We just knock them out, paralyze them, and then intubate them. Okay. So it says use of sedation and paralysis may permit resting of fatigue respiratory muscles, particularly during the first 24 hours. So sedatives and paralytics are great for rapid sequence intubation as well as relaxing the patient. So let's see. When patients are spontaneously breathing and have trouble triggering breath, setting the extrinsic PEEP at about 80% of intrinsic PEEP may allow for easier triggering. So basically, if we increase our PEEP close to where they have auto peeping, that's going to help them breathe easier for asthmatics. Reduce the incidence of air trapping by providing long expiratory times, which is another way of saying shorten your I time. Okay, and then your respiratory rate less than 8 breaths per minute. And your tidal volume 6 to 8, and your I time is going to be greater than 1 second. And then your flows are going to be much high, 80 to 100. Okay. So, and we want a descending flow pattern because we want to make sure we want some alveolar recruitment and make sure that they are oxygenating well. And again, your frequency is going to be less than 8, so they're going to be breathing really slow. All right, really slow. So we want to make sure that since they're breathing slower, we want to make sure that they're breathing out a lot more carbon dioxide. All right, so now we have some with neuromuscular disorders, your Guillain-Barré's, your myasthenia gravis, those types of patients. It's going to depend on where that paralysis is. That's going to determine if they're going to need full or partial support. That's also going to determine if we're going to go negative or positive pressure ventilation. That's going to determine if it's going to be a non-invasive versus invasive ventilation. And most likely we're going to use some assist control because we want them to relax, and they may not even be able to breathe depending on where the paralysis is. So therefore the control mode will come in handy. Right? So we want volume control. Why? Because with neurological diseases, there's nothing wrong with the lungs. It's just the neurological pathways, or it could be the neurological part of the brain that tells the diaphragm to drop or the muscles to breathe. In terms of your chest muscles, pulling the rib cage, all that stuff. It could just be some type of neurological disconnect. So that's why their lungs are fine. Right, so we're going to put them on volume control. We're going to put them in tidal volume of 6 to 8, and we're going to maintain that plateau pressure less than 30. And again, our frequency is going to be 8 to 16. All right, so because normal breath is 12 to 20, so it's okay to drop them down to 8, which by definition is partial ventilatory support, if depending on where the paralysis is. Okay. So if I want some inspiratory flow rates, it's going to be greater than or equal to 60 to meet patients' need. Most likely, I probably would keep it at 60 because, again, there's nothing wrong with their lungs. All right, waveform, constant or descending flow patterns. Those are the two wave patterns that you're going to see in volume control. And in a PEEP, we want +5 just for the physiological PEEP. And then we want them on room air, which is 21%. This basically signifies that their lungs are okay. We want to start them at 21%. We want to start them at room air, because before the disease, they're breathing fine. So when they're starting to become paralyzed, either from the head on down or from the feet on up, they're still breathing fine. It's just the neurological aspect of it. All right, so if I have a closed head injury, I have due to status post trauma, something falling on my head, or I played football and I lowered my helmet and I got jacked up because I missed the person I was going to tackle, and I tackled the cheerleader, right? That can cause some head injury. All right. So any type of head injury, again, we want to you put them on pressure control. We want to make sure we have some PEEP, but not too much PEEP, because actually it says here pressure control and PEEP can actually increase ICP. These patients often have normal lungs, so high alveolar pressures can be transmitted to the blood vessels, thus affecting venous return from the head. Monitoring for elevated ICP can help to evaluate this effect. So again, with pressure control, it can increase it, but if we start off at a low pressure, we should be okay. With PEEP as well, we just got to monitor the PEEP. So with these particular patients, I probably would start them at a +3, but most likely the doctors still put them on +5. And it says monitor for increased ICP. So now that's going to be more of nursing. They're going to have all the monitoring stuff. But when you're in the ICU, you're going to see the numbers as well. So you can start trending it yourself if you start to see the ICP increasing. It's saying monitor for increased ICP and hypoxemia, so that a rapid increase in ventilation and oxygenation can be instituted if needed. All right, so let's just say if they have head injury, you may or may not intubate them and mechanically ventilate them, but most likely you will, because you want to control that pressure. And with ICP, if they're coughing, that's going to increase ICP. So you want to make sure that, number one, you have a secure airway, and number two, you're able to get out some secretions, but yet not trigger so much pressure that it's going to increase your ICP. When there is acute uncontrolled increased ICP, maintain your PaCO2 from 25 to 30, or titrate the ICP if it is being monitored. With this one, that's going to be hard to maintain, because you're going to have to constantly get blood gases, to be honest with you. So most likely, if it's uncontrolled, we're going to just drop those pressures. And then we're just going to make sure that the CO2s are either within normal, or they're a little bit lower, or they might be higher, I think, depending on if you want permissive hypercapnia with them. If not, then pressures will be low, just so that we don't increase that ICP, and it will just be up to the nurses to try to stabilize that ICP. All right. So if iatrogenic hyperventilation is used, so we might have to use that. We might have to cause some type of hyperventilation so that we can get the good minute ventilation, because we're doing a low pressure, so therefore low volumes, right? This should be only temporary, with the PaCO2 gradually returning to normal levels in 24-48 hours. All right, so if we have iatrogenic hyperventilation, we hyperventilate them so that they can get good minute ventilation. They're blowing off some CO2. So therefore, I think if you blow off your CO2, you start to vasodilate, so that should drop pressures. Okay, so based on that, and you don't want to drop the pressure too much, right? So we'll drop it for 24-48 hours, and then it'll just go back to normal. All right, and then sudden increases in PaCO2 could trigger increases in cerebral blood flow. All right, so that's where we got to be careful with increasing our CO2, because it can affect the blood flow. Therefore, it could increase ICP. A normal response to acute increases in ICP is hypertension with bradycardia, which is funky, and that has a name. That has Cushing's response, and I think he probably talked about that in 210. All right, history of participant condition that occurs within 1 week of a known clinical insult. So we're talking about ARDS. I'm going to go over ARDS next week. I should have done it this week, but I didn't. So I'm going to go over it next week. All right. So with ARDS, again, you're looking at diffuse bilateral alveolar infiltrates on chest radiograph. Excuse me. Not fully explained by effusions. With this, you're going to see some type of reduced lung compliance. And we've talked about that. Stiff lungs, increased static compliance. That's going to give you the hint that you might have some ARDS. And then with ARDS, you might have some pulmonary edema. There might be some type of infection, and there might be a leakage of fluid inside your lung. And it could just possibly be due to some lung injury to the point where, yeah, you are leaking fluid. Oops, here we go. And then you might have some refractory hypoxemia. That's, again, hypoxemia that cannot be resolved by oxygen. Okay, so your PaO2, FiO2 ratios would reduce. So with ARDS, most likely we want to make sure we're able to oxygenate and ventilate the patient. You can go pressure control or volume control. Most likely we want to control the pressures because we don't want to cause barotrauma, or we don't want to cause any type of pneumothorax. All right, so again, we want to keep the SATs greater than most likely 90%. And with ARDS, they say to start at 100% oxygen. You want to hyperoxygenate them because they're not getting enough volumes, okay, because the lungs are stiff. So therefore, if they can't get enough volumes, guess what? You're going to have to ramp up on your respiratory rate to get that minute ventilation if you're on volume control. All right, so if you're on pressure control, you're going to have to ramp up that pressure, but you're going to have to be careful because you can cause some barotrauma and alveolar trauma. So you want to be careful with your pressures as well. You want to use some extrinsic PEEP, right? We want to set the PEEP at a level that prevents alveolar collapse. All right, but yet we don't want to overdistend them. So we want to make sure that the patient can still oxygenate very well, but yet we don't want them to fully have their alveoli collapse. Again, if I can't stabilize oxygenation, sedate, paralyze, and you can change positions on them so that they can breathe better. Cardiac output and hemoglobin levels should be optimized. All right, so then we're starting to talk more about optimal PEEP studies. Again, with ARDS, you don't want to increase so much PEEP because that's going to add pressure that can create some barotrauma. All right, so when we want to keep our plateau pressures below 30, like usual, by lowering tidal volumes 4 to 6 if necessary. Okay, they have a ARDS net, or they have an ARDS net protocol, and this is the protocol right here. Below 30 pressures, 4 to 6 mLs per kilogram. So we know, since they have stiff lungs, we have to drop down in tidal volume, right? So therefore, if I drop down in tidal volume, I got to increase respiratory rate, right, to get that minute ventilation. All right, so we want to make sure that they are getting good volumes, but we also want to make sure that we're not causing any type of trauma to the lungs. Allow permissive hypercapnia if necessary. All right, unless there's a risk of increased intracranial pressure. All right, so that would be the worst part if you have ICP and you start developing ARDS. That would be a very difficult patient to handle. Thank goodness I haven't had that. I don't think I think I had an ICP patient, but they had a shunt in the back, so they're able to drain out some fluids. So patient was still okay on mechanical ventilation, and that was when I was a student. So nowadays I don't get to see that. So hopefully you guys do. And the rapid rises in PaCO2 should be avoided. It should always be gradual because it does affect the cerebral blood flow. ARDS again here. All right, so deflation limit of slow pressure. Okay, so we haven't gone through pressure volumes yet, so I'm not going to deal with that. This next point, maintaining extrinsic PEEP. above this pressure range helps to prevent opening and closing of small airways and alveoli. So if I constantly open and close alveoli, that's going to damage them. All right, so most of the time, if I'm able to keep them open and let them distend just a little, but yet again keep them open, that's not going to cause as much damage. Okay, so again, when we're talking about CHF. All right, CHF. There's going to be two types of heart failures. You have left-sided, right-sided. Right-sided is going to deal if you have just fluid overload in your extremities. You have a lot of swelling, edema, and that would be right-sided heart failure, right? Because the right side can't pump as much blood, so blood gets backed up, and then it all gets backed up all over the extremities. So if I have left-sided heart failure, the left side of the heart can't pump blood to the aorta to the rest of the body, so it gets backed up into the lungs. So we're going to be dealing with left-sided heart failure, okay, and so that's where we get that pulmonary edema. All right, so we have here we want to make sure that we find a mode that's decreasing work and breathing. So definitely we're going to want PEEP with our CHFers. Right, we want to make sure we push that fluid out of the lungs. All right, so again, when life-threatening hypoxia occurs with severe CHF, PEEP or positive pressure ventilation may have beneficial effects. The beneficial effects is that we get to push fluid out, as well as we get to have more alveolar recruitment, so therefore that's going to increase our oxygenation. All right, so careful evaluation of effects of positive pressure ventilation on hemodynamics. Primarily we're thinking about PEEP, because again, if I ramp up on my PEEP, I can start to put pressure on the heart, therefore it's going to decrease cardiac output. And we talk about hemodynamics more at the end of the term. Okay, so the use of volume control or pressure control is recommended, and it's CMV. Okay, volume control or pressure control, CMV, is recommended. All right, and then tidal volume range is moderate from 6 to 8, so that's still the same. Frequency 10 or more breaths, that kind of is the same. So we normally go 12 to 20, so they're saying 10 to maybe 16, 15. And peak flows at 60 liters a minute. We want faster and shorter inspiratory time, longer expiratory time. You want to use a descending or a constant waveforms. I probably would go descending, because again, descending, you still have that pressure as it ramps down. Okay, eye time ranges from 1 to 1.5 seconds, so they can breathe out a lot more. All right, so they're going to be starved for oxygen because they're going to have a lot of fluid in the lungs. So once that I push all that fluid out and I get that alveoli open, I'm going to have better gas exchanges. So then therefore I'm going to start to generate a lot more CO2, or a lot more CO2 may be trapped. So by opening those up and getting the fluids out, I have better gas exchange, and I can breathe out a lot more CO2. So if I have an ABG with respiratory acidosis, so I have a high PaCO2 on a CHFer, is because they can't, the fluid in the lungs is trapping or is creating that gas exchange to go almost to a standstill, to a halt, that you can't ventilate, and so it traps that CO2 in the blood. So if I can get that alveoli open, I can push the fluid out, I can get that CO2 out, so I can start getting out of respiratory acidosis. All right, so we're setting our PEEP 5 to 10. Again, we want to make sure we have that pressure to push the fluid out and to distend that alveoli for better oxygenation. We want to start at 100 and titrate quickly down. Again, we don't want oxygen toxicity, but we still want to make sure that once the airways are cleared, alveoli distended, that we want to oxygenate as much as possible. Okay. Monitor SpO2, ABGs, urine output, electrolytes, and systemic hemodynamics. Most likely, urine output, electrolytes, and hemodynamics are probably going to be for nursing. You're going to have to do your job and just look at the O2 sat as well as your ABGs. Okay, but I'm not saying don't look at urine output, electrolytes, and systemic hemodynamics. I'm just saying that it's going to be more of the nurse's job, but glance at it once in a while. Okay? And that's it. That is chapter 7. Hopefully that helps you guys out. And hopefully you guys like these, that you can just sit down and just listen to them. You know, you don't have to worry about, you know, oh boy, I'm sleepy, I drove, I got in late, or oh, I studied so hard for the exam. I mean, this is a little bit more relaxed. I'm feeling more relaxed. Maybe I should just do this and then just tell you guys just to watch my video, and then I'll just sit there in class and just eat and drink and just take a nap, and then by the time I'm done, you know, you know, it's time to dismiss you guys. So I'm just kidding. I'm not gonna do this, but you know, I think I might just keep these on for later terms, so that they have something extra. Or if they didn't get a concept, I can they can just play these and they'll understand. All right, so guys, so thank you so much. This is chapter 7. I'm going to start working on the other ones so that when I'm gone, that you guys are able to understand the concepts. So hopefully Mr. Priska will do a really good job deciphering my PowerPoints and the concepts of the book. But if not, then you have these to fall back on. Okay, guys, thank you so much, and I'll catch you in the next one.